Thank you very much to everyone for joining us in this patient and family breakout session. So we'll allow a few more people to join us. It's a bit of a smaller group than we'd hoped, but obviously the mainstream's captivating everyone, which is good. We're going to have some powerful testimonies from previous tracheostomy patients, those with existing tracheostomies and laryngectomies. And later, we're going to have a bit of an open forum, which we can probably discuss as a group, if it's a nice close-knit group like this, about how you as patients and families feel we should improve tracheostomy care going forward. I'll point out there's 2 further patient and family breakout sessions throughout the day, one for the US time zones, which you might be able to catch later on this afternoon in the UK time, and one for the Australasian time zones, which will be going out our evening time. I'm glad to be joined again by Alan on the sofa here, who you'll have met in the main session this morning before this. But we're also joined by Jenny and Claire. So Claire will be coming on hopefully live from university. She has a permanent tracheostomy following a hemorrhagic stroke, age 13, and Jenny's her mother. And we've also got Tanvia, who required tracheostomy following ECMO for COVID, but she's also a clinical scientist at Manchester Foundation Trust. We've got a lot to get through, and it might take us a few minutes to sort out some of the technology, trying to play the videos here. So I'm going to try and jump straight in with our first powerful patient testimony, which is a video that Helen Brown recorded for us. I can see she's with us as a guest as well. She has 4 children, 2 of whom have tracheostomy, and personally, as a father of just 1 kid, I can't thank her enough for giving us the time to record this with Brendan. So we'll try and get that up and running now.
Hi, Helen. Thank you for joining us to talk a little bit about tracheostomies from your perspective and the perspective of your family.
We're not seeing your video there. We're just seeing the desktop.
You telling a little bit.
You shared the application window rather than your desktop.
1 second. So stop sharing. Barry's telling me off as well. Start sharing again. Did you get the sound?
Yes, we were hearing it.
Lovely. Right, so desktop. Is that screen? Stand
Yeah,
up?
screen. Yeah, screen.
Yeah. Right, try again.
About your journey and your family's journey with tracheostomies.
So my husband and I live in the West Midlands, and we have 4 children. The youngest 2 of whom both have tracheostomies. They were both born prematurely, and we now have a very extremely rare genetic issue that causes respiratory problems. They're also gastrostomy fed, and they were both 24/7 vented, but we're now down to just 1 of them vented overnight. So they're quite complex. They're quite unique boys, and yeah, life has changed quite a lot since he arrived.
Yeah, I'm sure. What does a typical day look like for you then?
So I guess to a degree, a typical day depends on whether we have care or not, and that makes quite a difference for us. But it will be, we get the boys up, normally do trachea tapes straight away with both of them. Throughout the day, it's a case of, in terms of their trachea anyway, monitoring secretions, chest physio if needed, nebulizers when needed. Both of my boys are quite adept at pulling their trachees out, so I've done trachea changes in places you could probably only dream of, and I've probably done thousands in the past 4 years. So regularly, most days, it also involves a trachea change as well, at least one of them.
And I imagine with 2 little ones with tracheostomies, you don't travel light.
No, actually a couple of weeks ago was the first time that we as a family have been able to go away anywhere. And even then we only did one night. Prior to our third son's arrival, we were a family that were away most weekends, off out exploring, going away. And it's just not particularly feasible or easy with one trachea child, never mind 2. The vent makes quite a big difference for families. It's not just the trachea. I think if you've got the vent as well, that makes life a lot more difficult. But yeah, you have to take an awful lot of equipment with you wherever you go. And obviously in the cases of our boys, they need waking care as well. So one of us needs to be able to stay off. And
you mentioned carers and equipment, but perhaps we'll touch on those separately. But I'm really interested in the sort of access to trained carers and how you found that, and whether that took a long time to set up, and how you find on a sort of day-to-day or week-to-week basis how the provision of carers is for you.
It's a struggle, and I don't think we are unique as a family in that being the case. It is an issue for an awful lot of families with children with tracheostomies. It's a struggle from the moment you're told that that's the option for you. The hospital are great and are honest with you, but it's not a quick process, particularly if you have a tracheovented child, of getting out of hospital. Our third son was in 18 months before his care package was ready to go. With our fourth son, we were able to whittle that down very quickly. So he was out by 8 months because we knew the system, we knew how to make it work. We struggle hugely for carers. So last night we had no care, so I've been up since 4 a.m. today because my husband and I have to split the night shifts between us when that's the case. And that's a 4th missed night shift in a week. Again, that's not unique to our agency. I think particularly post-COVID, there's a real lack of community-based carers. We're being told that people just don't really want to go into it anymore. So to find a carer is difficult enough. To find one that's also experienced in paediatric tracheostomy care is very, very difficult indeed. It has the added, in term time, gives the added problem if we don't have a carer, my son can't go to school and my youngest son can't go to nursery. I'm often left out of pocket because we still have to pay for our youngest child's nursery placement when he doesn't have care. And our 4-year-old desperately needs school. He desperately needs to go and have that interaction after spending such a long time in hospital. Yet often half the week he can't go because there's nobody to take him. So it's a real struggle.
You mentioned the pandemic. I mean, it sounds like things have got a lot worse in the pandemic, but if we went back, say, 18 months to before COVID, did you have the same problems accessing care then, do you think?
I'd say it's probably got a bit worse, but it's never great to start with. I think the issue for us when we first came out is that our boys were very complex and they needed experienced people, and they were very, very hard to find in the community, and that's always, it hasn't always been the case until as a country we place more emphasis on social care and the amazing work that they do, and doesn't seem as a country we always necessarily value it to the level we should. But it has got noticeably worse in the pandemic with the lack of carers, and we went through a stage where we weren't able to have carers who were working on other packages because that increased the risk of COVID being brought into our home. So that made things worse. And now a lot are just looking elsewhere, unfortunately.
I mean, you obviously know other patients and other families in your situation. I mean, do you ever feel that you're sort of competing for the same small pool of carers with other families?
Yeah, we absolutely are. And, you know, I've known carers be pulled from ours to go and work elsewhere from families who are even more in need than we are. As I say, it's not unique to us. I think one of the frustrating things is that there's also no kind of national picture in terms of care, particularly for children with tracheas. So what you receive seems to be essentially a postcode lottery in terms of the amount of care you get and who provides it. It depends on where you live and how helpful your CCG commissioner is, and that shouldn't be the case. You know, it should be very much based on the child.
You mentioned that you were sort of stuck in hospital with one of your children for 18 months waiting for the care package to get sorted out. Have you got a sense of how much of that time you were ready to go home and you were just waiting for the care package, as opposed to how much of it was waiting for your son to be medically well enough, if you like, to be discharged?
Close to 6 months.
Okay. Just putting a pound sign on that wait is quite interesting as well, isn't it? It's a huge expense. It was interesting you said that obviously with your second child things were a bit quicker because you knew the ropes, and I think that's quite a common story, and I just wondered if you got a sense of, you know, if you could bottle up some advice for other families in your situation. Are there any top tips that you could recommend, not just to families, but maybe to healthcare staff as well? Are there any things that we can do to speed that process up?
I think a lot of it is, you know, we were very naive when we first went into this about the agency and what you require of the agency. For example, you know, what you should be looking at is things like, well, have they discharged from this hospital before? How quick do they discharge? How do they train their staff? How free is their nurse assessor to be coming in and actually signing people off? Because that's the stuff you need to know. But actually, until you've gone through that process, you've no idea about it.
And did you feel the onus was on you as parents to sort of drive that sort of process and finding agencies and finding people?
To a degree, yes. And I say that the hospital were as helpful as they could be. But at the end of the day, it's your child and it's you who's in hospital every day. So in a sense, it's you who wants to get home. So you have to drive it in a sense. And it's often down to, you know, a family and how confident and how competent they are with dealing with these professionals. Because again, for a lot of families, this is stuff that you've never ever encountered before. And I think certainly second time round, I was very happy to tell people what I wanted to happen and when I wanted it to happen by, and it did then happen. The first time you're so overwhelmed by it all, you know, it's hard to get your head around it, never mind actually then drive the process to get yourselves out the door.
How tricky was that to try and sort out the equipment that you needed to go home as well?
Certainly second time round, that was easier, and I think it is getting easier actually. I think hospitals realise the benefits of, so for example, we're under Birmingham Children's, and I know during the pandemic they were loaning equipment out to help get children home, and that makes a big difference because it shouldn't be the lack of a suction machine that stops you from going anywhere. That
phrase in itself is it's quite remarkable, isn't it? That can be the thing that stops this huge care package from happening sometimes. You mentioned that the challenges accessing education and nursery for your children.
Yeah.
That's something that I know is not unique to you and your family, and it isn't unique to the pandemic. Can you tell us just a little bit more about the problems that your children have faced trying to access education?
Well, obviously over the past year and a half, we've faced the very unique challenge of COVID and AGP, which has caused no end of issues, not just for us, for all trachea children. I'm not alone in saying a lot of families feel their children have been unfairly singled out. You know, as it stands, when my son goes back to school, he'll, as far as I'm aware, will still need to be moved to a separate room for suctioning, whereas children can now come in when they're confirmed close contacts of COVID and cough and splutter all over the classroom, yet my son's education still needs to be disrupted and he needs to be moved. At a point, he was unable to access transport because of AGP. That has caused a lot of additional stress, and it, you know, I appreciate that was completely unforeseen, but that comes, I guess, on the background of the fact of how difficult it is to actually access the education in the first place, never mind all the issues you've then got when you get there. It is the case of having a CCG commissioner who will fund it. You know, you have to be lucky enough to be in an area where they'll agree to do it. We are incredibly fortunate that where we live, our commissioner is now very willing to do that. Our youngest son is 2, and I know in other areas won't fund them going to nursery because, you know, they're too young in their eyes to go, which is just incredible for me, because it's the children with needs like this who need to be there more than anyone to learn from their peers. And as I touched upon as well, you're completely dependent on the availability of carers to be able to go with them. It is so frustrating when your child can't go, particularly when you work. You know, my husband and I work full time, yet we're constantly having to juggle, have missed days at school because a care company can't, you know, fulfill a shift, and he can't go. Never mind the impact it has, I guess, on their education as well. Our 4-year-old is in mainstream, and we've found, you know, again, everyone's very willing, but it's not something they come across very often. So we've had real problems in sorting out how that care provision, what it looks like essentially. So, you know, do you have a health worker who assists with educational issues? Do you have an educational worker who's trained up in health? If you have an educational worker, who's then responsible for overseeing the work they're doing from a health point of view? You know, how is a head teacher in a mainstream school to know whether somebody is suctioning a child correctly? There's just so many issues to overcome, and none of it is straightforward. And that's not to say that people don't want to do it, but there's no national guidance. There's no guidance anywhere that says if you've got a child with a tracheostomy who wants to attend a school, this is what you need to provide. You know, everybody kind of feels as though they're working in the dark a bit.
You speak very passionately about education and access and you know, not wanting to feel that your family is being discriminated against in any way, which is, you know, entirely right. What do you think are the things that the healthcare world needs to tackle?
I appreciate it's very hard for staff, certainly from a hospital point of view. Obviously they deal with things in a hospital, don't they? And it's very hard for them to envisage the situations that can arise outside of that. To a degree, I guess a lot of it then comes down to the community staff. And what it is then is, you know, having staff who are either experienced or aware of the specific issues around a tracheostomy. I think our lives have been made much easier because our community nurse happens to be an ex-ICU nursing pick at our local hospital, and, you know, it's all about trachees. We don't have an issue, you know, we never have an issue with stock. You know, I've heard stories of parents being told they need to use less suction catheters, you know, like that's even feasible. You know, if you come across somebody in the community who understands trachees, who understands what that means in the home, what that means if you're out and about, the respite parents will need, and what that means for education, I think that can make the world of difference. When you're coming up against people who have no clue, that's where the problems really begin.
You've already mentioned a couple of things about what perhaps I'll say the education system could do to make things better, and I appreciate exactly what you said, that it's not just about education or health. It's all merged together.
Yeah.
If we could wave a magic wand and change things tomorrow, what do you think we should tackle in terms of, say, schooling and provision of education? What would make your life easier?
I think probably guidelines on what a mainstream school can do to help, what a special school can do to help, the issues that they might face. Things like, as I say, our head teacher's great. He's been really, really helpful, but he's never had so much as a tube-fed child in the school before. And when I brought up the idea of having teaching assistants trained in trachea care, so that if our normal carers couldn't go, they'd be a backup. He said, how am I meant to assess them on this? Where do I even start? Nobody had the answer, because there is no other child locally with a trachea in a mainstream school, so nobody knows the answers to these questions. And what it often results in is our local, our education key worker and our community healthcare nurse going off to find other areas where this happens. So I think there needs to be a sharing of stories, particularly a sharing of success where it works, and pass that on to other areas to say, look, this is what we're doing and this is how it works.
Yeah, no, I think you're exactly right. We tend to almost reinvent the wheel every time we come across these problems.
Local hospitals in particular being unable to deal with tracheostomy children. So, again, I don't think that's unique to our area, but we can't actually attend our local hospital because they don't have trachea trained nurses there. So, we live probably 16 miles or so from our nearest children's hospital, and we face the journey there every time there's an issue, simply because there is no one else locally to look after them. It's tough because I guess as a parent, when you're taking your child into hospital, you don't want to be the one who's providing care. And I've had to do that on several occasions when we've turned up and there's no trachea trained staff, and that is just the last thing you want to do when you've got an unwell child. You're worrying about providing that care. It's tough. It's really tough. What you're taught in hospital and is very different to what it's like at home with the trachea child. And it's that preparation, and I think a hospital does its best, but in a way their hands are tied because they don't see the other end of it. Nothing can really prepare you for it, for the utter chaos. It also brings a lot of joy, but it also brings a lot of chaos to your life as well. And just getting used to carers, having people in your home is just a massive thing for so many families. It's not straightforward for anyone, but it's life-changing, I guess. It's life-changing. We have carers in our home every night, and it is completely life-changing. You're not prepared for that when you go home. You're not necessarily prepared for the feeling of how much is on you, particularly if you've got a poorly child. We're really fortunate. Our boys are much better now, but certainly our third son, when we brought him home, was still quite unstable. And it can be, on a bad day, it can be overwhelming. It can feel relentless. It's completely exhausting, knowing that it's on you at home to look after this child. And as I say, we're fortunate. We've got a good hospital that I know are there at the end of a phone if we need them. But that doesn't stop you feeling alone sometimes at home when you're not quite sure if you're doing the right thing.
Well, Helen, it's fascinating talking to you, and thank you ever so much for your time, giving us these unique insights into your life and the lives of your family. I'm sure people will be fascinated to hear your story. So thank you very much.
Hopefully that shared okay with everybody. Helen, thank you so much for that. It's a really powerful window into just some of the issues that are in the community and that I'm sure a number of you listening share. I can see Claire's with us. Claire, as somebody literally joining us from university, I wonder if you've had similar experiences as Helen described there, trying to access education. Might just have to take your mute off. I don't know if I can do that. Oh. No.
You're still muted, Claire. Press on mute. Claire, you're still muted. Can James unmute from remotely?
I'm trying to. I don't think I can.
Can you hear us?
There we go.
Yeah.
It was fortunate for me because I'm able to receive a limited admission amount of education in the hospital. That it was well within what I believe I would have been able to advance in school. I value education highly, and I always have done, and probably always will be.
Yes, could I add to what you say, Claire, as well? To say, yes, hospital education was a lifeline for you, 45 minutes a day provided by teaching assistants that visited the hospital. And I do think that actually I hadn't even thought of that, but you've come up with that. That is something that could be a recommendation. Why have kids in hospital for months and not give them anything? So well done, Sheffield Children's Hospital, for arranging that for long-term stay patients. So that was just a sanity thing when you're really stuck in hospital. And Claire used to use eye gaze equipment for communication because she was track event for 2.5 years and didn't really regain speech for 2.5 years before breathing in the day and getting a speaking valve. I have to say Sheffield was very good for having a care team in place, better than Helen's find an agency job for children. This is so the children's situation in Sheffield is very much better than adults. So there's a specialist NHS care team. The carers are band 3 support workers. They've had 3 months training before they arrive in the community, so they're ready to go, and they accompany your child to school or nursery. Obviously if they're off, then a parent has to go. Helen, I really admire you for managing the two. I think that's a very, very tough job. With one, it's just a case of, okay, well, I was planning on going to my now only part-time job today, but I'll go into school with Claire instead. But with two, it's just, it's really so much tougher. So for children, education's available in Sheffield. I think that was the question, wasn't it? I was nearly running on to something else I was going to say, but I think in Sheffield, they will make an attempt to get you back in mainstream education if that's appropriate for you. And there's a range of good special schools in Sheffield as well for some other kids. So in Sheffield, there's the view that you are going to leave hospital with a care team, with help from a care team and get back to school. And teaching in hospitals, a little taster teaching for people who are stuck there is also a great idea.
Thank you both so much. Jenny, I was just wondering, did you have similar experiences with that transition from the hospital into the community?
Really, we didn't have the experience waiting for a care team because Claire was still covered by the paediatric care team. But I could see there were people stuck in hospital long term like us who were waiting for transfer to rehab or housing adaptation. So we were waiting for a lift we needed a lift in our house. and we needed other equipment. Claire did used to be hoisted and so on. So we wanted house adaptations, and we thought we'd have that done when we were at rehab so that Claire's sisters wouldn't be homeless. In the end, we had to wait 7 months to go to rehab. So the sisters were homeless for a month. Then we went to rehab for 8 months. When we got back, everything else was in place. So it wasn't the care team. But I would like to comment on adult transition home, because I can see that that is very different. So now let's look at the adult situation in Sheffield. There is no care team, and what's more, there's no community training either. So for the adult situation, it's very much worse. Now, when you transition from a child to an adult, the CCG just finds you an agency. You look on the website, it goes, fine, this agency does people with brain injury, spinal injury, tracheostomy, etc., etc. But what actually happens is the agency then recruits some staff who arrive, and some of them may be absolutely baffled by a tracheostomy and they have no experience of that. And then they have to be trained from scratch, which basically means you have to train them. And also then you have agency carers who are on low pay, they're on 0 hours contracts, and you work with an agency who has an attitude that can best be called cynical in terms of having any old paperwork filled in. Who cares if the list of meds is correct? It's very poor. So what many people do, and Sheffield supports this, is have a direct payment. And then you can have carers who are the familiar people who are competent at their job, who have a better, it's still not as good as an NHS job, I feel, in some ways, with pension and other NHS rights, but it's a much better setup than having an uncaring agency in charge. So we have a direct payment arrangement now. There's still the question of how do those staff get trained? Now, if you're in hospital, the staff will be trained, and I did do some investigations on this a couple of years ago, and I found that people who, for example, had a spinal injury and were going to go home with a care team, perhaps including track event care, had the carers turned up at the hospital and got trained in situ. So the issue is there's no further training once you're home, because there's no community training for tracheostomies in Sheffield for adults. So I think that the care training has to happen while you're in hospital, and I think that could be a limiting factor for you getting home, as much as having building work done in your house, or perhaps waiting for different social housing to be provided.
Jenny, when I left hospital, went to my sister's, she was trachea trained on the ventilation unit. And as a layperson, she did extremely well. It was very good. I then went to the community nurses where I live, and there was a mishap on the first visit. I don't think they're not unknowledgeable. They just don't have the experience. In South Manchester, at the time I was being treated, there were 2 trachea patients in the whole of South Manchester requiring nursing visits. So there's just not enough time and patience for them to get that experience. I will say, after that first mishap, the specialist practitioner from the hospital fixed up a couple of meetings with the community nurses and gave them some training. And that was the only mishap we had. And they were also very good at, I'd have the regular nurses come in, but they'd ring up and say, can my colleague come and see how you change dressings? So they sort of learn amongst themselves, which was a fairly good sign. But I quite agree, I don't think it's the same everywhere.
And I think, as Lee's summed it up quite nicely on the chat, that it's a bit of a postcode lottery, and that's obviously not right. We've got a lot to get through, so I was just going to move on to the next VT, which is a bit more ICU centric. But before COVID, so our next speakers are Julie and Carl. And in 2015, Julie required a tracheostomy during a fairly arduous intensive care stay following a surgery. and today she wanted to share her experience with us with a chance of bringing hope and some inspiration to others. So I'll just try and share that again now. Audio. That's the one.
So welcome to this next session where we're going to hear from Julie and Carl about a patient and their family's first-hand experiences of what it's like with a tracheostomy in an intensive care unit. And it's really important as healthcare professionals that we hear the impact of some of the things that we can do on our patients and their families. So I'm going to hand over to Julie and her husband Carl to tell us a little bit about their story. And I'm going to first ask Julie just to tell us a little bit about how she first ended up with a tracheostomy on an ICU. So over to you, Julie.
Thank you, Brendan. In November 2015, I underwent surgery at a private hospital for a sleeve gastrectomy. The operation went okay, but I did have some problems, a lot of pain after it. So I was discharged from hospital 3 days after the operation. Approximately 4 days after I was discharged, I returned to the private hospital in quite a poorly state, where on arrival I was very quickly rushed to the Royal Stoke Hospital with a diagnosis of sepsis. So I was blue light ambulance to the hospital. The last thing I remember was the paramedics running through the A&E doors, and after that point I became unconscious. I can't remember anything else then.
So after that, so Julie's unconscious, and sort of she got taken into surgery, and I was told to return to hospital later that day to visit Julie after she had this emergency surgical procedure. On arrival, I was told that Julie was extremely ill and that she had a 1 in 5 chance of surviving the next 48 hours. So I was taken to the critical care pod where she lay. I could see that she was attached to a ventilator and wearing a mask, a full face mask. I was informed that a number of Julie's organs had failed and that her lungs had collapsed. I was then told that Julie was then left using the mask for a couple of weeks. Then the clinicians told me that Julie wasn't getting enough oxygen using the mask and that she would need to have a tracheotomy installed. When I saw the tracheotomy, I was very upset due to it seemed to be very sort of roughly installed, to be fair. There's lots of blood. Julie already had an A-line, I think, installed on her neck to facilitate the dialysis, and so there's already a lot of blood and wounds and things, and the tracheotomy being installed with lots of very visible black thick stitching and lots of blood, etc. That was very distressing indeed.
So the next thing.
Yeah, I mean, there's clearly a lot we can talk about from all those experiences, isn't there? I mean, it sounds pretty frightening for both of you. I mean, as healthcare professionals, we often focus on what we think patients think are important, and it's really important to hear those sort of stories from people like yourselves. Obviously, we're particularly interested in tracheostomy care today. So, Julie, do you remember what it was like first waking up with a tracheostomy?
Well, I was quite sedated when I was coming round, so I do, but it was, you know, I wasn't really aware of my body, if I'm honest, initially when I came round. So I just remember being sort of lay flat on my back and very sedated and paralysed, and sort of, I remember just looking up at the ceiling tiles. I knew I couldn't talk. I didn't understand why. Nobody really explained or mentioned this. I couldn't, and I couldn't move any part of my body because I'd been I'd been sedated in the coma for quite a while, so I'd lost all the use. I couldn't feel the trachea, if I'm honest, and I was aware something was there. So
okay. So did the tracheostomy hurt or feel uncomfortable?
No, it didn't, to be quite honest. No,
Okay.
I couldn't feel it, if I'm truthful. The things that were uncomfortable was the daily cleaning regime of the opening and the equipment. That could be quite painful. Also, when they had to change the kit, replace kit every 72 hours on it, that was quite uncomfortable and painful for me. But
okay.
it in itself didn't hurt. No, I couldn't say that. No.
Okay. And when you first came round the tracheostomy, you were still attached to a ventilator, so you describe all of that tubing that was essentially sticking out of your neck. And we've talked in the past about what it's like breathing on a ventilator. And can you remember or put into a few words what it was like trying to breathe when you're attached to a ventilator?
I'd say compared to normal breathing, it feels much gentler, very shallow. You feel like you've got kind of enough oxygen, but it feels very low quality, low levels. Yeah.
Okay.
So,
and did breathing like that make you feel scared or anxious?
No, I couldn't say I did at all. No, because I hadn't got the memory of the normal quality of sort of breathing. It was, yeah. So no, not really. No.
Right. Okay. And you've already said when you first came round, you were really weak and you weren't able to talk, and obviously that can be incredibly frustrating, I'm sure, for trying to talk to the teams around you, but also to your family. So if we just talk about your communications with the medical team first of all, Julie, I mean, can you remember what it was like trying to talk and trying to communicate when you first came round?
Yes, it was very frustrating and stressful with the clinicians because you know, you were relying on them picking up what you were saying with your lips and you were trying to exaggerate. That requires an awful lot of energy as well. So if you're very poorly, that is really stressful and tiring. And I can remember, you know, just giving up at times because I just didn't have the energy to do the exaggerated moves. If it made it extra difficult if a nurse or a clinician didn't have a good command of English. And I can remember one incident in the night where I was turned and set up and I couldn't get across to the nurse and how I was uncomfortable where she put me. And I was in quite a lot of pain that night and it was very, very stressful that evening because I couldn't move.
Right, gosh, yeah, I'm sure that was pretty grim.
Yeah.
What about talking with your family? Maybe from your perspective, Julie, first, then I'll ask Carl what he made of it all.
So yeah, that was very anxious and stressful again, and very exhausting again, similar scenario, because you're relying on the lip reading. I desperately needed to talk to Carl about things about our finances, my job and employment. I was worrying, and I just couldn't do it. Basically, couldn't communicate, could we? And that was really, really stressful. I can remember thinking I'm going to have a heart attack here because I just couldn't get across what I needed to get across for me. And bearing in mind, I was almost in lockdown, you know, in my body.
Gosh.
So, yeah.
And how about from your perspective, Carl? I mean, it must have been incredibly frustrating to see Julie trying to talk, and were you able to understand her?
No, I couldn't do the whole lip reading thing at all. Just one of our friends who came to visit managed to kind of very easily read lips. and that was great for that one visit. But the rest of the time, it was between us, as Julie said, here trying to get over just very basic kind of instructions, etc., and requests and whatever. It was really frustrating. And I know the staff in the CCU were they're very sympathetic, but they couldn't really offer any support because, of course, that's not, I don't know what their remit was in terms of that, but they were very sympathetic, very kind of, just persevere. But it was just really difficult. So we were given, for example, this electronic gadget that you sort of request on things that you wanted, like a drink or something or whatever. And it didn't work, but not only did it not work, but Julie couldn't lift her arms up anyway, so she couldn't
use my fingers.
So she couldn't the sort of,
obviously now in ICU, so all the doctors, all the medical staff, the speech and language therapy, and obviously that all continued when I went on to the long-term ventilation.
Mute your microphone if you're listening in.
And I guess that was kind of useful because not only for her to get over yes and no to things or whatever, but it started making her use her hands as well. That was kind of, but that was the communications thing was, and especially with asking the clinicians for information and updates around the trachea and bits and bobs. Everybody told me different things. That was, again, that added to the frustration a bit.
Yeah. Okay. And I think, Julie, you mentioned that you managed to get a little bit of voice going with a little electrolarynx, a little voice box.
I did. Yeah. Yes.
Was that the first time you were actually able to say something then?
Yes. Yes.
Yeah. And how did that feel?
Oh, it felt great actually. The nurses, well, the clinicians got me set up with it, and Carl was coming to visit, and I said hello, and you were really shocked. Yeah. But it does take an awful lot. It was lovely, wasn't it? Yeah. It takes a massive amount of energy to use that box. And if you're in critical care, and there's a technique, it's quite deep where you have to thrust the sort of your voice and project it. So, but it was fab. It was really good. Okay. Yeah. So,
can I ask you a little bit about eating and drinking? I imagine when you first came round, you probably had a little tube in your nose, and we were doing a lot of the feeding that way. But as you started to recover, do you remember wanting to eat and drink?
Oh, I was desperate. But I mean, my condition made it a bit unique because I was only allowed to have a sip of water anyway an hour. But it wasn't painful swallowing at all. I couldn't feel that. But that first sip of water, shall I say, was like it was nectar. Honestly, it was it was like amplified the taste of it. It was like honey nectar, and I literally couldn't let it go. I was like, don't take the cup away. It was so delicious. So yeah, but it was gorgeous. Yeah. I wasn't.
Fantastic.
Yeah.
So, have you got any top tips or advice if we're a bunch of healthcare professionals listening to this? Any top tips for people looking after patients like you or families like you where there's someone with a tracheostomy?
Yes, let's go through these.
Yeah, you can do. Yeah.
So, I mean, one thing we thought about was encouraging staff to take the opportunity to take a quick basic course in lip reading. There's lots of them on the internet. You can sit and just spend a couple of hours getting used to the basics. I think that'd be really useful for anybody who spends a lot of time supporting patients with trachees, conscious patients with trachees. Also, just try to enable anything that sort of clinicians or support staff give to the patients and the families. Just try to sort of be aware, try to make sure that they work, basically, that they work. And perhaps just spend 5 minutes just saying to them, listen, this is how you switch it on, this is what you need to do, and just to give them a bit of confidence and that kind of support. Next, just try to be as honest as possible and clearly describe to the patient and the family what the kit is, what it does, why it's there.
Yes. Yeah.
Perhaps even a laminated checklist just for the clinicians to talk through. This is what the patient needs to know. Yeah. This, and this.
Yes. For me, when I was going through the weaning process, I would have liked to know to see what was going on, and I understood. what was happening. That would have been so, you know, I need to get my head in the right space for that and understand it.
So,
and then the other thing, the tubes went over my left arm, so that's really prohibited. I don't know whether there's some way in which that can be sort of scaffolded or something off, because that does impact your physio. So
also the Julie's tube kept popping out.
Yeah.
And it then made a really harrowing kind of squealing noise. So when I was sat there, I'd sort of, you know, tried to grab the tube and sort of reconnect it and things.
Yeah. So that was
okay. Well, look, it's absolutely a privilege to hear these insights from both of you, both as a patient and as a carer, and as healthcare professionals listening to this, you know, it really brings it to life, the sort of things that we should be focusing on. And the thing that's really struck me from talking to you is just that sentiment about your first drink. You know, it's often something that we don't always think about, particularly when we sit at the end of the bed swigging a cup of tea talking about your care. So that's a really important take-home message. So look, from all of us, thank you ever so much for giving up your time, both of you, to share those insights. We really appreciate it. Thank you very much.
Thank you.
Thank you so much then to Julie and Carl for speaking there. I was going to come to you, Tanvir, if I can. So there's an awful lot in there about communication. Is that something that resonates with your experience in ICU?
Yes, definitely. I mean, similar to Julie, I regained consciousness and realised I had a tracheostomy. And I wasn't prepared for it when I was initially put to sleep and ventilated. I am a healthcare professional and I am well aware of the tracheostomy, but nothing prepares you for having one. I can definitely relate to the frustration of trying to, I mean, I remember when I was still very sedated, but I remember feeling so hot and I, like Julie said, I wasn't able to move and I couldn't remove my own blankets, and just trying to get that across to the healthcare professionals and, you know, everyone looking after me, and they did a fantastic job, but it took a lot of energy and time just to tell them that I was hot. You know, I just wanted the blankets to be removed. And I really agree with Julie, you know, I mean, communication is just, it's so frustrating when you can't, it would be just so easy, obviously, just to talk, but you can't. We also obviously couldn't have any visitors then because it was during the pandemic. But I remember speaking to my husband on the iPad, and he used simple things, you know, to say just blink once if it's a no, or a yes if, you know, twice if it's a yes. But I would have loved to have had just some simple, just even picture cards, just even 5 picture cards, you know, of sort of healthcare professionals asking if you know, are you comfortable, or do you want to drink? Are you in pain, or you know, a toilet issue or something. Similar to, you know, how I communicate with my baby, who obviously can't talk. You know, the sort of basic things that you check for. And that would have been great. And I can really relate to the drinking of water. I mean, I don't think I was allowed to, but it was the only thing that I wanted was just a glass of water or a cup of tea. Yeah, I mean, the professionals were great looking after me, but I think I would have liked to have had it reiterated to me that I've got a tracheostomy and what it means. And I'm sure it was explained to me, but I just don't remember, and I didn't remember it then. And I think I would have liked to have had that repetitively, sort of every day, even just going through a checklist, you know, this, you've got a tracheostomy, you won't be able to talk. Because I do remember repeatedly trying to talk and then realizing that I couldn't. And that was just, I think, with the sedation and being on ICU, and it got better. But yeah, just to have that reiterated again and again, I think would have been helpful.
I agree with you about the drinking water. For me, it was ice cold ice cream. It was just bliss. It really soothed my throat.
Yeah.
So that was a great pleasure.
You remember it, don't you? You just remember these small things.
I think I mean, certainly as a healthcare professional, I'll be taking away the lip reading advice is something I'm just trying to do it through experience. And you'd think by now I've had plenty of experience, but I'm absolutely awful at it.
I think we've all realised it during the pandemic, haven't we? When you don't realise how much you rely on it actually when people are wearing a mask, but yeah, and how important it is.
We'll move on to the next long and final long video that we've got, which is a chap called Malcolm Babb, who a number of you might know. He's the chair of the National Association of Laryngectomy Clubs, and I should probably plug their stall. They've got a booth on the main forum, I think, which you can go and visit and find out a little bit more about them. So one last time trying to share the screen. I've not stopped sharing, have I? We need sound. Yep. No.
Thanks to Malcolm Babb for agreeing to talk to us today about his story and his work with the National Association of Laryngectomy Clubs. So welcome, Malcolm. I thought we'd start just perhaps if you just to tell us a little bit about yourself and your journey with your laryngectomy.
In 2001, I was diagnosed with cancer of the larynx. I knew what it was. I was a heavy smoker. I knew the signs, and I had radiotherapy. But a year later, the cancer returned, and then there is only one alternative, and that is to have your voice box removed, a laryngectomy. I'd always, before that point, been very reluctant, and I did not like the idea of having a laryngectomy. I thought my quality of life was going to be so different afterwards, but in the end, there was no choice, and I had to have the laryngectomy and my voice box removed. My profession, I was a school teacher, and I did not think I would have the good enough voice to get back to that work. But as time went on after the operation, I realised there was a chance, and I took it and went back working as a teacher for 4 years. I was able to work quite effectively, speaking as I do.
At what point after the laryngectomy did you realise that you'd be able to get back to work and using your voice again? Because I'm sure that was obviously a huge thing preying on your mind when someone says you're going to have a laryngectomy.
I had the operation in June, and the following March I went into my GP surgery, and when I went into the room I didn't know whether I was going to ask him to support early retirement on medical grounds or say I want to go back. And the words that came out were I want to go back. But I knew I could do it. Some adjustments were needed. I needed to realise that the things I said that were not heard or understood by the pupils. And I acquired a computer projector. So from that point on, all my lessons had slides that went on the board that gave the basic information, and then when I spoke, it backed up what I was saying, even if at times I couldn't be heard. So it took a long time to make the decision, but I have absolutely no regrets. regrets on trying it. I was only 51, a rather young age to be giving it up.
Yeah, fantastic. I mean, that little story in itself is inspiration for anyone who's facing a laryngectomy, I guess. So yeah, well done.
Can I talk about my voice?
Please.
Spin cells. But when I use the valve, I develop an high pressure inside the windpipe end, and I blow the seal on the base plate product. A laryngectomy in America wrote a memoir called I Left My Voice on the Dining Room Table, meaning when she went out, her electro larynx was left behind at home.
I know you've got very heavily involved in NALC. I wonder, could you tell us a little bit about NALC and how it works, and then your involvement in the club?
Hospital in Chesterfield, where I live, were very keen for me to be involved in supporting patients, and so I would meet patients before they had a laryngectomy. There's a local support group, and I never went to it until would be 6 years after my operation. By then I was retired, and I realised that even 6 years down the line, a support group had something to offer. Living, breathing through an hole in your neck, there's quite a few complications, and other people will have had those complications. And sharing experiences, you learn new ways of coping. Now was formed in 1975. It was part of Macmillan Cancer Support. What we do is we provide hospitals with information packs for use with their patients. Over 50 hospital trusts use our information resources. We produce safety items like wristbands, stickers to have in your car. But possibly the most important work we do is locally. We've got over 50 affiliated groups. So around the country, if a patient is facing a laryngectomy, then they get the opportunity to meet the patient beforehand. So we support patients before and after their operation. Of course, now we work in quite a different way to in 1975. We got a website, and everything can be downloaded from the website. We got a YouTube channel, and over 50 videos are watched every single day on that channel. So we're providing information in a variety of ways, and that's our key role.
Fantastic. Okay, well, it's great work. I know because of your involvement with all these different groups and meeting lots of other patients with laryngectomies, you get to hear firsthand not only about the problems that you've experienced, but the problems that other patients face. And perhaps we could break this up into two parts and talk about problems that laryngectomies encounter before COVID, and then perhaps we'll talk a little bit about the additional problems that the COVID pandemic has brought. But have you got a sense of the common recurrent themes that laryngectomies find problems with, and perhaps things that people like me and other healthcare providers could maybe be a bit more aware of or think about when we're meeting with and trying to help manage patients like yourself?
I never managed to find exactly how many laryngectomies are living in the UK at the moment, but there aren't very many of us, so clinicians don't see us very often. My GP, I'm the only laryngectomy in that practice, when you go into hospital. Many of the staff and nursing staff, for example, will not be familiar unless they work on an ENT ward. They probably will not have seen a laryngectomy or worked with one. And we are vulnerable because of the way we breathe. And I know you are aware of incidents that occur in the worst cases. It leads to a death where resuscitation is carried out inappropriately. So there's a constant job of education, and as staff are changing the churn of staff, there are new staff coming in all the time. That job never ends. So I have been involved with contributing to tracking days. For example, at Doncaster Royal Infirmary, they have an international masterclass, or they used to before COVID. And I would go there and deliver a session on laryngectomies. I provide presentations at universities to people who are training to be speech and language therapists, for example, or radiographers, people who work in radiotherapy. So that job of educating staff, it's not to me, but I know of friends who, when they've had hospital care, things have been done wrong. They've realised quite quickly that something's going wrong. There's no point putting a mask over the laryngectomist's mouth and nose.
And is that something that you get a sense from the community that people are fearful about going into hospital because they think things might go wrong, or are patients generally reassured that they're going to get a good standard of care?
There's some fear, some level of fear, I think, and it takes away one's confidence when you encounter ignorance of the state in which a laryngectomy lives. It shakes your confidence.
I'm sure. So, I mean, that's something we could focus on straight away, isn't it? That if, for example, you had to go into hospital, if you were met by staff who understood your condition and you were cared for by staff around the clock who knew what your problem was and knew how to keep you safe and knew how to manage any problems that arose, I'm sure that would give you a lot more confidence in the care. And probably, yeah, okay. Can we just talk a little bit about the COVID pandemic, because that's obviously brought a whole load of new problems with concerns about aerosols and breathing and airway interventions and shielding, and perhaps just focus on a recent paper that I know that you have co-authored, where you've looked at shielding hospital admissions and mortality amongst laryngectomies living in the UK. But perhaps you could just tell us a little bit about some of those things that you've found from some of that work, and again from the contacts that you've had.
I think the most important thing about the paper are the weaknesses it highlights. It was hoping to answer some questions, but in the conclusions, I think we find we haven't been able to answer all of them, and there is much more work to be done. For example, are laryngectomies as a neck breather more vulnerable to COVID than the rest of the population? And I would assume tracheostomies may feel they're in the same position as a laryngectomy there, because they're having to manipulate their trachea tube just as I have to manipulate, work with my stoma and touch it and so on. 1,200 patients took part in the survey, but the coverage was quite uneven. I mean, I think it was a miracle that this survey was completed at the time it was. The pressure that hospitals were under. There is some evidence in the paper regarding mortality that suggests we may be more vulnerable, but the numbers are quite small and come mainly from the London area. project is, and this survey should be the start, and there should be more to follow.
I remember you telling me that you were hearing concerns about the impact of COVID on the delivery of sort of regular services to laryngectomy, such as speech valve maintenance, which can obviously have impacts not just on communication, but nutrition potentially as well. I mean, have you got any stories from any of your contact about how COVID and the problems on the NHS service has impacted that sort of day-to-day care?
The pattern across the country was quite different. Some hospitals did not change a valve for quite a long time. We were given valve plugs to put in place while we were eating and drinking. But there was no education about how to actually use a valve plug. Now, some hospitals just never stopped changing valves. It's horrible to live with a leaking valve. If you've got a valve plug in, you can't speak. And some trusts kept under service. Others found novel ways. For example, I'm aware of patients being visited at home by staff and having their valve changed while they were at home.
Is there anything that you wanted to say or to challenge us about these differences in care around the United Kingdom?
In Scotland, the voice is seen as integral to the person. And in 2014, some legislation was passed which entitles anyone with a speech or voice impairment. They're entitled to have the equipment they need provided at no cost and the necessary support in using it. A motor neuron disease patient living in Scotland could have their voice recorded, voice banking, at no cost. The same company helping a patient in England, they would have to recover the costs either from the patient themselves or perhaps in charity. Now in the laryngectomy world, electrolarynxists are difficult in some places to get hold of.
We've covered problems that patients find. We've got challenges for healthcare staff, challenges for our healthcare systems, challenges for the NHS, and also throwing down the gauntlet for politicians to sort it out as well. So yeah, that's really interesting discussion, Malcolm. I think we've covered lots of bases there. You stand as an inspiration, Malcolm, to anyone having to undergo or got the prospect of undergoing this sort of surgery. So I thank you for your time in talking to us and sharing information, and also thank you for all of your work with the National Association of Laryngectomy Clubs.
Lovely. We're all still here. I think we've gained some more people. Thank you very much to Malcolm. And like I say, the NALC, or the National Association of Laryngectomy Clubs, have got a booth in the main forum if you want to find out more. So from personal experience, well, not personal, but I've been down to A&E during COVID to see a laryngectomy patient who'd been told that he had to wear his face mask over his mouth and nose during his A&E attendance. Alan, do you think that staff awareness is still an issue around tracheostomies and laryngectomies?
I think it is in certain circumstances. Obviously, if you work in one specialism, you don't necessarily know about the others. And I'm not very au fait with people who've had laryngectomies and what that entails. For example, when Malcolm was talking about increased infection rates, I think some of that may have something to do with the background as to why you had a laryngectomy in the first place. If you're immunocompromised because you've had radiotherapy, for example, I don't know. But there are certainly sort of within the community, I experienced 1 or 2 nurses, for example, who were not very aware of what tracheostomies were. There was a certain amount of interest, but not very much experience, which I've explained before. So yeah, it's Malcolm's a very inspirational person. That was a very good talk. Very good.
I think we've got time for one more short one. So all of these, you'll notice there's been a lot of editing done on some of these talks. They'll all be available afterwards, and we'll put the full versions up on the YouTube channels and the NTSP website. And I believe this session is being recorded as well, so that people can watch it back later. I'm just going to try and share that last video, and then we'll have a bit of a debate for the last half an hour or so. One.
I don't really remember the tracheotomy being put in place. Yeah. All I do remember is waking up and I couldn't talk, and then I was terrified that this had happened and it had gone and wouldn't come back. So the first time I spoke, it was just like a new world. It was like, I didn't have a voice before, you know, emotional time to be able to talk. That was the biggest, one of the worst things I know is when you can't go to the toilet and when you can't get somebody's attention quick enough. I know they're busy and everything, but it's so horrible. That's probably the most horrible thing happened in there, is that you just feel really, it's not something degrading, isn't the word, but you don't want to be doing it because you've got, you know, somebody's got to come in and clean you up and everything. It's just not being able to communicate. Maybe if you had a red board or something to stick up and said, I need something now. Well, yeah.
I said it would be casual.
Yeah. No, but and then when you can talk, it's like, well, then you take it away from me as soon as you put it on. You can only have it for half an hour. It's off again. Yeah. I think that, well, the only thing that wasn't really nice was the suction that you have to do, and I think not knowing really what that was for, and I know it was for now, I know what, and I probably did once it had done a few times, but at first you think, why, and then how often it was done. Does it need to be done that much? Because it's a horrible thing. That was probably whether it just was communicated of what it was for and how often you needed to do it.
Yeah.
That was probably the main thing, really.
Yeah.
I've got so much gratitude to all of you, I really have, I'll tell you. Thank you. Because without you, I couldn't have done it.
So that was David, another one of our COVID patients who spent a long time on our unit this year. He's touched on a lot of stuff we've already discussed, really, Alan. But one thing we've probably not had a little chat about is suction. What was that like?
Yeah, it's very my story is very similar to David's, I think. The first few times you do it, bear in mind, you're full of COVID pneumonia. Your chest is full of gunk, for want of a better word. You've got blood from the surgery site where the trachee's been. So it's very uncomfortable to start off with, and obviously very strange. You know, it's strange enough waking up with this thing in your throat, but then learning how to clean it is uncomfortable but necessary. And I have to say, once I got home, I mean, during my time on the vent unit, on the recovery ward, I was maybe being suctioned 5-6 times a day, mostly after I'd been nebulized, but sometimes if I just had a coughing fit, the nurses would come in and do a suction. But once everything calmed down, I was doing it 3 times a day after nebulizing, and it was sort of okay, as long as you didn't send the tube down too far. It wasn't too bad. Just as a weird aside, David's comment on the toilet situation, I can remember losing a catheter while I was in there, but I was so full of virus and drugs, I wasn't laying in an ICU bed. I thought I was on a cruise ship on the Adriatic, and we had to pull into port to have a new catheter flown in. That's how crazy the situation was.
That's ICUs and drugs and a bit of COVID added in for good mix, I think. Just on the suction, I had a colleague once who, well, I had a colleague called Betty, who's unfortunately not with us anymore, and she had a tracheostomy. She was an ICU nurse who had to have a tracheostomy for a short while. And when she came back to work, she saw me sort of as healthcare professionals. We always, you know that suction's awful. We don't know what it feels like, but you know it must be awful. And I approached the patient and said, I'm really sorry about this, but I just need to give you a little suction. And she kicked me in the back of the shins and said, never say it's just a little. Just be honest with people. Say this is blooming awful, but this is why it's needed. The next part of the session is kind of an open forum. What we want from you guys, certainly from our patients and family members in the audience, is to get involved now. We're on Teams, so it needs a little bit of structure to it. What I'm going to ask is, well, what we've already asked is on behalf of the healthcare professionals, and we're going to feed this back to the mainstream later on in the day. What is the one thing that you as patients and families think we should focus on to improve your tracheostomy care? I'll come through to the panel to start us off with little bits and bobs, and then open it out to the rest of you who've joined us. I can see as the other meetings finished, we're getting more and more people. To add a bit of structure to this, we put out a little survey before the conference, and I'll just quickly share the responses from that with you so you can see where it is I'm coming from with what I suggest we talk about next. So, pre-conference survey. I think I should have bought a new laptop for this. This is very slow today. Let's go from the beginning. Right, that's us. So we had 159 responses in total, which is quite impressive. Most of those did come from healthcare professionals, but I've singled out, and you'll see why, 66 of them came from patients and their family members. And from all around the world, got people joining us from all over today, but most of our responses came from the UK, the US and Australia. We're going to focus on what you guys want, but I thought it was worth just having a look at what healthcare professionals think we should be focusing on. And in some ways, I'm glad that they're telling us that we should be focusing on the things that the main conference stream is focusing on. So from their perspective, we've probably got today about right. Improved multidisciplinary team working, staff training and knowledge, and linking into that safety and improving quality and safety. Some stuff about clinical particulars, and not as high as I'd like, some of the issues that you guys are seeing out there in the community. In terms of patient and family responses, very different. And I think that's one thing to take away from this is, unfortunately, the things that you see with the most responses there's probably not all that much content in this conference today focusing on those things. So that's why we have this session, and hopefully next time around in 18, 20 months time, ITS7 will be focusing on these sorts of things a bit more. Your top one there was consumables, consumables and equipment, which we'll come to last, I think, because there'll be quite a bit to talk about there. Staff training and knowledge did rank highly in both, so our healthcare professionals are obviously aware that you see that as an issue. I've got a broad term there, which I'll explain in a bit more detail, which is more specialist care more often. Patient and carer education, which I think is key, and that sort of links into carer support, which is probably where we'll start. And actually, before I start messing about with my screen, I'll try and pass that straight over. So working through the top 5, if you try and raise a virtual hand or ping something on the chat, I think I can see those coming up whilst I pass over to Jenny. An example of one response to this was, in terms of carer support, we need to be training the wider family and friends to give children the possibility with staying at grandparents and the opportunity of a normal life. So that's the sort of thing that we're looking at. Jenny, in terms of for you and Claire, would it have benefited you to have other family and friends trained, potentially giving Claire that opportunity of overnight stays elsewhere and perhaps giving you the occasional rest as well?
Well, actually, it wouldn't have benefited us at all, because I'm a widow. Claire's sisters were 10 years old at the time, and we have no near family, and my friends all work. But other families in Sheffield do certainly have grandparents having the kids and can give parents a night off, for example. So it wouldn't have benefited me, but I'd like to just turn this into the adult version and say, yes, that sort of training for other family members and friends in the case of kids, and for more carers in the case of adults. So what it would mean for Claire, for example, is there could be other people trained up so Claire could go out with them. Claire does go to gigs and things in the evening sometimes, and she goes with me. But it would be good if she went with just a social carer who's not so trained up as Claire's university carer, Karen, who you can see in the background there. So yes, I think this is an issue for both children and parents. Sheffield have got this for kids because Sheffield have paediatric community facing practitioners who can and do train other family members. Nothing for adults, no community training for adults. And I think nationwide it would be a good thing to have it for both children and adults. And that means adults with tracheostomies who require a care with them. So perhaps adults with perhaps mobility issues and so on can go out and do their own thing because the people they're with have had the necessary training. So the answers are yes.
Is there anybody else out there want to speak? Just pop your mic on and crack on, I think. Yeah, go on, Lee.
Hi, that was music to my ears, Jenny. Yeah, I agree that community, it's very important to get the right resources for our trachea patients in ICU and say the respiratory wards and looking at discharges. But absolutely, when you're at home and you haven't got those teams around you to support you, it's a big area to develop. And we have developed a community team in Lancashire and South Cumbria, but we're aware, it's a new team. And there's got to be the influences there to develop those teams, nationally.
Mm-hmm. Definitely.
For the next bit, I'd use the broad term more specialist care more often, which I should probably explain a bit more. So some examples of the things that I'd included in that were that we need more specialist practitioners, that we've missed regular airway checks. We need more airway checks more often. Do I still need a tracheostomy? I've got a growing child. Is my tube the correct size for them still? Alan, I know we've spoken in meetings before about community specialist services, and I know we've got Lee joining us from a community specialist service. And Helen mentioned, and Jenny has mentioned, this postcode lottery. Do we just need more of these services and for them to be more accessible?
Yeah, I think you've hit the nail on the head with the word specialist. You know, if you've got a specialist trachea trained team, it's going to make life a lot easier for everybody. When I had that mishap with my first community nurse visit, the first thing that happened was the nurse practitioner from the hospital went and gave some teaching to the community nurse team. Then they in turn brought colleagues. I was a bit of a curiosity, I guess. And I think the problem is tracheostomy patients are so few and far between in the community. You don't have enough experience of seeing them. So they were bringing someone new every time. Can I come and see how the dressings have changed, etc., which was a good thing. So yeah, I think if there were more specialist teams around the country, Helen's point earlier on that there need to be national guidelines is just as valid for adult teams as it is for paediatrics.
Lee, go on. Can I try and bring you in? Because you guys have got an amazing service, which is just something we basically need to replicate. How did you go about creating it? Were you involved in that?
Thank you. Yes and no. So, but in answer to how we developed it, I think you need to go back to, I think it was something that Helen said, was about having good relationships with your commissioners. So in terms of NHS care, that's and the sort of, like, say, the specialist level care that you're talking about, we were commissioned by the Lancashire and Midlands Commissioning Support Unit. So our consultant physio, they essentially went to that team and talked about the number of patients that she knew across Lancashire and Cumbria, because you're right, there's not that many, you know, but there isn't necessarily yet a national database for that. But she talked to the commissioners and said, look, you know, I know of 10 people that I could potentially help them with their trachea, potentially help them to get the trachea out. And if she knows of 10, there's lots more. There's a lot of young adults and older adults living with tracheas that just haven't been reviewed, that maybe have fallen off the list of ENT or what have you. So they might be under their district nurses or their GP care. But you're right, there's no sort of specialist trachea service out there to review them and see what they need. So we were lucky that the commissioners and the team at Preston were able to develop that service, and there was a pilot service, so it ran for a year to see if it was effective, and it was. So then they commissioned it permanently, and we'd love to see those teams nationally. So I'm very happy for professionals to email us and ask about how that happens. It's very much the same as getting resources in acute hospitals. It's about writing a business plan and making sure you send it to the right people and getting yourself in a meeting with a commissioner, essentially.
If you look at decannulating 1 or 2 patients,
yes,
or by reviewing them regularly and giving them that opportunity, not only do you give them a great chance at their life, the cost implications must be significant.
I think you've just written, I think you wrote the talk I gave to our trust yesterday, because so that the impact, it shouldn't be about money, should it? But the impact in terms of savings to the NHS if we can get those trackies out, is huge. Just in terms of it having to have a monthly trachea change, you know, if you have to go in as an outpatient, not only during COVID is that risky, you don't want to go into a hospital and have your trachea changed, but we can save a lot of money by doing those trachea changes with you at home, or teaching your carers or yourself or your family or whatever, if you wish to do those changes, if it's safe to do so in the community. But you're right, so there's a lot of financial savings that a team like ours can bring to the NHS, so then the money can be spent on other things. But it's the impact on your health and well-being and that of your family. So if you can get your voice back, or we can help with your eating and your drinking, lots of our patients are in specialist nursing homes, and then they can go back, if we can decannulate them, they can go and live nearer their family and see their family more easily.
I think Lee and Emma Forster are presenting some work on a fantastic patient education resource as well, which I should be about to tweet the link out to.
Please do, thank you.
And that fits in hopefully with the next bit, which is the quality of patient and care education. So put simply by one respondent, they said, "Why wasn't I shown how to care for my tracheostomy earlier, just to help me get out of hospital sooner?" I think we were going to go to... No, it's you again, isn't it? Sorry.
It's me.
So Alan, what sort of training did you receive, and did you feel prepared for discharge?
Yeah, I think I did. I've got to say the ventilation unit at Wythenshawe were extremely good, not only in training me to do the suctions and the nebulizers, but also in training, because I live alone. I was going to stay with my sister for several weeks straight after hospital. So they actually, the physios and the nurses on the vent unit trained my sister up. She must have done 4 or 5 2 or 3 hour training visits with them. So when we got back to her house, she was okay. It's a little bit trepidatious. It's something neither of us had ever done before. So the first few times, you're not really used to it. But I have to say, she did a fantastic job. And as I say, in 18 months of, well, in almost a year of having the trachea, we only had it blow out on us once. And that was when I committed the cardinal sin of taking my hands off it when the ties weren't on, and then coughing, and out she came. So, but in terms of training here, it was very good. But I'm also aware from the comments that Jenny and Helen have made, it's not always the same everywhere else. So that's another thing. There could be, or there should be, some sort of national guidelines that everybody has to work to. In an ideal world, that's what you'd want.
Has anybody else got anything to say on patient education or patient information? Where do you find out what you need to know?
I think I'd just add about oversight in terms of training and who's got that oversight, particularly once you're at home. You know, for us, it's one thing being trained to do it yourself, but then actually as a parent, you're getting home and you're having to then oversee the carers. So it's not just being confident enough to do it yourself, it's being confident that actually you're happy with what the carers are doing on top of that as well.
You're right, Helen, and a lot of our patients use care agencies, but it's the care agents has that accountability, so they should have, if they're providing you with tracheocomp staff, they should have that accountability to check that, you know, that their staff are, you're right, performing things correctly. And listening to you if you have your concerns. Have you found that's not the case though?
I think that's where it's postcode lottery again, isn't it? And at the end of the day, the agency, with the best will in the world, and we have some fantastic carers, but equally their bottom line is money.
Yeah.
They are a profit-making company, and they are there to make a profit. And so what we consider should be the most important thing isn't necessarily is what the agency considers to be the most important thing. And we have to take, it's in an agency's interest to have a shift covered, is what it's being cynical. And so you could then argue that, they've then got oversight of how well trained that staff member is.
Yeah, I agree. Yeah, it's very, very tricky. Not to bang on too much about our team, but yeah, we would like those national guidelines. We'd like a national network of community specialist teams to kind of develop all this work and support all this work. And it's a long plan. We're a new team and it's on our 5-year plan really. But watch this space. We want to do a national forum, a bit like this, every 3 months to try and get families and other professionals together. That we've got lots of ideas, but it's the start of a big processing community, I think.
Yeah, I just think it can't be right that accountability is with individual agencies up and down the country. It just has to be looked at from a national point of view, surely, you would think.
Yeah. There aren't any national community guidelines at the moment. So things are being transposed from acute into community. So it's another thing on everybody's list.
Just to comment here that if the community care was joined up with the NHS, then there would be a national standard, and there would also be connectivity with the NHS resources of training consultants, etc., to refer to if necessary, and so on. That's what the Sheffield Children's Hospital have done, but the adults don't. So you might say medical care could be a central theme for the NHS and need not be sent out to private care agencies where profit is actually much more of a motive. Conditions for carers are actually very poor as well, and really there's a lack of concern as to what actually happens on the ground. I have to say, from my experience, and I don't think my experience is unique, I don't want to black all care agencies, but I was very deeply unimpressed by the care agency we had before we moved on to direct payments.
Yeah, I agree. A lot of in my neuro rehab background, direct payments is a much better way of getting the care that you would like. But I think, like everybody said, getting trachea competent carers full stop is a nightmare, to be honest, in the experience of our team and our patients. It'd be interesting to see don't want to get too political, but it'll be interesting to see what happens in terms of the sort of NHS and social care developments that are being put through at the moment.
I think that's the key, and that's something that Alison's put on the chat, which probably I think is along the same lines, that we need to just be much more joined up about the training and the accountability and the authority. I'm going to move on very quickly to staff education, and I don't want to get too stuck down on that because there's a whole session, I think, later on chatting about staff education. Just, I guess, the important thing isn't so much knowledge and skills to patients. Is it more that you feel the person looking after you is confident in what they're doing, Tamia?
Hi, yes, I would completely agree with that, because you yourself you're in a very dependent and vulnerable position. That's what I felt. Even having the knowledge about what a tracheostomy was broadly, but I would have no idea how to look after it. And I mean, sometimes when I would have a coughing fit and, you know, I would need a suction, I wasn't aware that's what I needed, but the staff looking after me were very, very competent, and they would do it for me straight away. And that confidence was vital, because I mean, I think they could pick up on that, and it's almost like a troubleshooting thing, isn't it? And I don't think they have the resource to troubleshoot problems like that. But they, just from experience, I think that they know what to do, and that is so important when a patient is, you know, feeling so dependent and vulnerable with a tracheostomy. And it's your breath, isn't it? You know, you already feel like you've sort of got a noose around your neck that's, you know, tying this tracheostomy. And when you are feeling like you maybe can't breathe again, you know, it's vital that someone's there who knows exactly what needs to be done.
We are running over now, over. So the last thing which we do need to discuss is the rather overwhelming issue of consumables and equipment. So this was half of all the responses in regards to consumables and equipment were about one thing in particular, which we'll just see if that comes up. If not, I'll mention it at the end. Has Claire disappeared? I think
Claire's dropped off, but I'll answer with the comment she was going to make.
Just going to ask.
So Claire was going to comment on equipment. We bought our own suction machine because we want a suction machine you can put in a bag and not one that stops working due to its filter clogging when it's tipped over. So a portable suction machine obviously has to be portable in more than the sense that you can carry it from one room to another. You have to be able to put it in a day sack and take it on a climbing trip, or take it to school or uni every day. So you have to buy your own. So equipment's not very well thought out. I would just like to add that consumables, there's an actual NHS service for continence supplies. There's the excellent nutritious service for people with liquid feed. I know urology supplies are well organised with, you can order catheter supplies and so on for urology. It's just tracheostomy supplies. It's outsourced to a bunch of different customers everywhere, and it's really totally random how well it works, and it's entirely up to you to try and battle to get the right stuff. And there are sometimes delays in getting things when you think, I'm going to have to drive down to the respiratory ward and just beg for a pack of catheters, suction catheters, unless one turns up soon. That's hit or miss, but I think it's not well thought out. There could be some better thought as to what you actually need in terms of equipment, what you realistically need to exist in the community, and maybe the supplies thing could be tidied up as well to have a better national service.
Thank you so much, Jenny. Does anybody else want to talk on anything particular relating to equipment or consumables issues? No. So oddly, well, not
sorry,
oddly.
yeah, I was just going to add something. Hold on, sorry, am I off mute? Yeah. I was just going to add, I think a lot of it is designed for children or adults, I guess, in hospital. A lot of the equipment is what works in a hospital does not work in the community, and I think a suction machine is a very good point. You know, families and adults, I'm sure, need one that is transportable, not one that is designed to sit in a bed space. And the other point on equipment I would just wanted to add was that during COVID in particular, we have really struggled to get hold of things at times. Just a couple of weeks ago, we had to make quite a long trip to our children's hospital to get a ventilator circuit for my son, you know, which is quite an essential item, because we just couldn't get them in the community. And that's been ongoing since the pandemic began.
I hope that's upset. I could understand that in the first instance, because I think we were scraping around for ventilator circuits in the intensive care units, but it should have sorted itself out by now. That's a bit of a concern. I'm loving the suggestion of bibs being designed to change colour after 3 washes. It's good. Oddly, the one that got mentioned the most was trachea ties. And just that to me seems a really simple thing, because they're just cheap and nasty, and it's something that you wear all the time. I don't know why they can't be made of a breathable football top-like fabric. If ATOS, I know they're here today, want to pay me for a patent, I'd be more than happy to sell that idea. I'm going to wrap it up, I'm afraid, and I'm sorry to do so. We can continue the debates on Twitter. We can maybe leave this open for a little while if you want to have a little chat for the next 10 minutes. I'll probably just leave it running and you can chat amongst yourselves. Myself and Tanvia are going to go back into the main session a bit later and sort of give a brief overview of all the stuff that we've discussed, so that the healthcare professionals who've maybe gone off for lunch now are also updated on the important stuff that you've been telling us about here. I think it's important for healthcare professionals. So these conferences always give us lots of new ideas, and you come away with lots of ideas and things that you want to do. But I think now, certainly over the last 2 years, more than ever, we need a bit of motivation and inspiration to actually get out there and do it. And I thank you all for getting involved and trying to give us the inspiration and motivation to get out there and make some meaningful differences to you. I wanted to address one last particular response to the survey, and I'm going to keep it anonymous. So one respondent said that the one thing we could do to improve their tracheostomy care would be for them to be able to meet others with permanent tracheostomies, because they feel so alone. If we've achieved anything today, particularly with Malcolm's talk, I hope that one person, if they're here, feels a little less alone. Jenny, do you just want to briefly plug some of the many groups that are available for tracheostomy patients?
Very quick plug then. Tracheostomy UK, the Facebook group set up by Vanessa Smith. It's for permanent adult tracheostomy people, and people exchange very useful tips, filling in gaps because there's no perhaps professional carer to suggest what to do about the bleeding stoma, gunky neb pots and so on. We've got some good life hacks from it, such as put laryngeal foam over your speaking valve to still have a speaking valve but have a bit of protection from pollution and so on. Tracheostomy UK Facebook group, I recommend that to hang out and meet people.
Lovely, thank you very much. We've also got to the GTC forum, which has been plugged. They love having patients and families involved, and we're trying to do something similar to Lee, and I think we maybe need to join forces with an NTSP patient and family forum with a bit more of a focus, less on sort of engagement, but more you trying to push us in the right direction with the things we're going about trying to change, very much like this session has done today. I'll very quickly, sorry, go on.
No, that would be fabulous. And just to say, the link to our online resource, which is free for all patients and carers, I'll try and get that up at some point, but it's on one of the posters. So Emma Forster's poster is on the poster link, and it's got like a QR code on it, so you can just watch it and download it.
If you can, just pop it on this chat bar here as well, Lee. That'd be wonderful.
Yes, that's a good idea.
So just quickly to signpost some of the other patient representation at the conference, we've heard from Alan a lot, which we're very, very grateful for. Whilst we've been talking on the main track, which will be available to watch back over the next 30 days, is a talk from Anusha Gupta, who was a local GP who spent a long time again with a tracheostomy during COVID. And there's some of the team there, the Northwest Vent team, who helped Alan through so much. They're all involved in that talk, so I imagine Alan will be going back to watch that one. In session B, we've got the keynote speech from Michael Rosen, which again is going to go over some of the many issues that you can all relate with. The breakout session during that is the scientific breakout, which Tanvia has very kindly helped judge. But I know some of you out there have submitted posters to that as well, which I can't wait to see. Session C will be more on how the GTC are trying to improve patient participation. And please, please, please get involved with their patient and family group. There's also sessions similar to this running throughout the day. So if you want a bit more of this sort of thing, there will be one mid-afternoon for the US, which again is live like this. And the Australian session is pre-recorded, and that will go out this evening. All of the videos and stuff will be available through this, like I said, for the next 30 days. But also some of them will be available on the YouTube channels. I'm going to leave you and mute this, but just leave it running so you can chat amongst yourselves if you'd like. But thank you so much for coming.
Bye, everyone.
Thank you.